friends. Welcome to ACNS webinars. This is the second last session of the ACNS webinar in the month of March. We are here today with two great speakers who are going to talk about surgery of the carotids. The first speaker for today is our honored guest from Czech Republic, Professor Vladimir Benes Jr. He is a professor and head of the Department of Neurosurgery for Children and Adults, Second Medical Faculty, Charles University, and University Hospital Motol, Prague. Professor Benes Jr. is an expert in the field of cerebrovascular surgery, and he is a noted author with several publications in various peer-reviewed journals. We are so grateful to Professor Benes Jr. for accepting our invitation to be a speaker for today's webinar. He is going to talk about acute extracranial internal carotid occlusion and its management. The second speaker for today is our honored guest from China, Professor Dai Jiang. Professor Jiang is the Associate Professor and Director of Cerebrovascular Diseases Team, Department of Neurosurgery, Renji Hospital, Southern Campus, Shanghai Jiatang University School of Medicine, Shanghai. He was a previous visiting scholar at the Fujita Health University, Japan, and also Mayo Clinic, Rochester, USA. He is a noted author with several publications in various peer-reviewed journals. We are so grateful to Professor Dai Jiang for accepting our invitation to be a speaker at today's webinar. Today is going to talk about endovascular recanalization for chronic carotid occlusion. The chair for today's webinar is also an expert at the carotid surgery, Professor Takayuki Hara from Japan. Professor Hara is the Director, Department of Neurosurgery, Toranomon Hospital, Tokyo, Japan. Professor Hara reserves his specialty in the field of cerebrovascular surgery and neuroendoscopy. He is a prominent member of the Japanese Neurosurgical Society and also an international member of the Congress of Neurological Surgeons. He is a noted author with several publications in peer-reviewed journals. We are extremely thankful to him for accepting our invitation to chair today's webinars. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to sincerely welcome both the speakers and chair for today to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today, and a special thanks to Professor Vladimir Benes Sr. who has joined us. Thank you so much for joining. With that introduction, may I hand over this virtual podium to Professor Takayuki Hara.
Thank you very much for kind invitation, Dr. Raja and Yoko Kato, Professor Kato. And today, it's a great honor for me to have two great speakers. The first person, Professor Benes Jr. from Czech Republic, and he will talk about the surgical management of carotid disease. And the second person will talk about the endovascular treatment of also carotid disease. Because the number of patients who has ischemic stroke in Japan increasing now, so we Japanese neurosurgeons have a lot of chance to do the direct and endovascular surgery for ischemic stroke patients. So I'm very interested in today's talk. So Professor Benes Jr., please start your lecture.
Thank you very much for the invitation. It's a real honor to be part of this webinar. And my talk will be about acute extracranial carotid occlusion. And I will not cover not only surgical aspects, but I will try to venture into conservative management and endovascular as well. Okay, so I say occlusion is an underlying cause of about 10% of ischemic stroke. And in this setting, the poor outcome is usually the rule rather than the exception. Here is the outline of my talk. I will start with natural history, then cover pathophysiology and imaging. These three are all about collateral circulation and penumbra. Then we shall cover, as I already said, thrombolysis, endovascular treatment, and surgery. We shall have a short look what the evidence in carotid occlusion is like, and I will present my own series. And I shall try to propose a treatment algorithm for this condition. Let's start with natural history, symptomatology. Symptoms are usually dependent on collateral circulation. If this is sufficient and robust, there need not be any, and the occlusion is asymptomatic. We do not usually see these patients, and these patients do not have any worse prognosis in the long-term outcome. There's no higher risk of stroke distal to the occlusion when the patients are really and truly asymptomatic. Patients then can present with transient ischemic attack, with minor stroke, and progressive or fluctuating neurological deficit. In the presence, or rather in the absence of sufficient collateral circulation, the stroke is potentially very devastating. And let's have a look at the long-term outcome or long-term outlook of ICA occlusion. In 5 years outlook, you have about 50% chance of myocardial infarction, stroke, or death. So it's not a really benign disease per se. From the natural history studies, from a historical review, when the patient present with severe deficit, there's about 50% chance of mortality, 40 to 50% chance of severe disability, and about 10% chance of favorable recovery. So, this was confirmed in recent studies as well. 20% favorable outcome, 15% rate of death. In tandem occlusions, that is intracranial large vessel occlusion as well, the outcome is even worse than in ICA occlusion alone or in large vessel occlusion alone as well. So in order not to have your patients end up like this, we need to take an active approach. Pathophysiology is truly about collateral circulation. We can divide the stroke in this setting into two rather distinct or combined etiologies. First is intracranial vessel occlusion. That's usually embolic in origin due to distal embolization. The affected segment of the vessel is usually short and the vessel is usually healthy. So as we see here, MCA occlusion in a patient treated timely with mechanical thrombectomy, and the outcome was rather good. On the other side of the spectrum is pure extracranial ICA occlusion, which is a hemodynamic stroke in origin. There's usually an underlying atheroplaque, and that's usually the cause of thrombus formation and propagation. So as we see here, this patient with a carotid occlusion had undergone an emergent surgery and did actually well despite its small infarction. And then we have combination of these two strokes, intracranial and extracranial. So the resulting occlusion, the resulting deficit is a combination of the two. As we see here, ICA occlusion, MCA occlusion on the intracranial, and with a timely endovascular intervention, good outcome. So the final deficit is a combination of cerebral hypoperfusion from ICA occlusion, that's the hemodynamic component, and tandem large vessel occlusion from emboli. And in the presence of insufficient collaterals, the deficit can be very profound. As in any stroke, we have an ischemic core, distal tural occlusion, and we have a large penumbra that's dependent on the collateral circulation. And this is something we need to treat, or that is something what we are fighting for. And that will be the topic of the next section of the lecture. Imaging. Patients with symptoms of stroke, they usually come, and the first exam they get is a CT. That's probably good enough to exclude a hematoma. Sometimes you get to see a dense artery sign, but it is enough to be able to start the RTPA treatment, that is thrombolysis, according to the American Heart Association guidelines. Then you get CT angiography. In the ideal situation, you get to see all the 4 extracranial vessels as well as intracranial collateral circulation. And sometimes you get lucky and get to find an aneurysm or a meningioma. As we can see here, good bifurcation on the right side, occlusion on the left side, appreciated on the lateral view, on the transversal view, and the carotid canal as well. And if in the intracranial vasculature, we can appreciate PCOM and ACOM as well. Then, if possible, we like to detect the penumbra, and that is done by CT perfusion, or can be done by CT perfusion. We get maps that describe cerebral hemodynamics that allow us to identify ischemic core and penumbra, and eventual mismatch between the two. So, such as in this case, ICA occlusion, normal, non-contrast CT, and on the CT source images, we can see areas of decreased blood flow, increased area of time to peak, and increased blood volume surrounding this distinct area. So this is what we are looking for, the mismatch between these two areas. And if the patient was treated in time, you get this resulting CT, and you have a nice mismatch between the salvageable tissue and the non-salvageable tissue. It's about 1/3 of the penumbra. The ischemic core should not be larger than 1/3 of the penumbra. Otherwise, you risk symptomatic intracerebral hematoma. Apart from CT, we can use MR, perfusion, and diffusion weighted imaging. We don't do that in my institution, so I took the liberty and present a case from the literature. You see here diffusion deficit, rather corresponding to the perfusion deficit on the MR imaging, and the resulting infarct is like this. On the other hand, a small diffusion deficit in contrast to a large perfusion weighted imaging deficit, and the resulting infarct after timely therapy is only corresponding to the DVI defect. So the goal of imaging is fast penumbra detection. Okay, we shall move slowly on to treatment. Obviously, intensive observation in a stroke unit is mandatory for all patients, even those who are without any large symptoms or who present with transient ischemic attack only. We manage blood pressure, volemia, platelet function, etc. And then we have these three and/or their combination. Let's start with thrombolysis. It's the only evidence-based treatment in ischemic stroke and can be administered up to 4.5 hours from symptom onset. You get an early start because only non-contrast CT is necessary in this setting. However, ICA recanalization rates are very low, about 10 to 15%. That's caused by poor distribution within the clot and low local pressure gradient for the thrombolytic, mainly due to the large clot size, as we see on this one, that was removed surgically. Results of thrombolysis were summed up nicely by Maxim Mokin in this review, and we see that about 1/4 of the patients gets favorable outcome, about 1/4 dies, and the rest is disabled somewhat in between. Regarding extracranial ICA occlusion only, that's about the same, 1/4 favorable outcome, 1/4 mortality. So to sum up thrombolysis, it's actually better than no treatment at all, but the results are by no means satisfactory. It can be used as a bridging therapy to endovascular and surgery. Now I shall cover shortly the endovascular aspect of treatment. It has one great advantage against surgery. Endovascular colleagues get to address intracranial tandem vessel occlusion as well. However, we run the risk of thrombus fragmentation and embolization into distal territory that was previously unaffected or sufficiently perfused. There are some controversies in the ICA and large vessel intracranial occlusion. Mainly, is emergency stenting safe due to necessity for dual antiplatelet therapy? And what is better? Is it better to treat the ICA first or the large vessel occlusion first, or is it necessary to treat the ICA at all? Obviously, if you treat the ICA first, it takes significantly longer. A large series published a couple of years ago by Advax, the largest so far that I was able to find in the literature, that treated purely ICA occlusion. There were 107 patients, high revascularization rates in the 90s, and 2/3 of the patients achieved a favorable outcome, that is MRS 0 through 2. However, about 1/5 of the procedures were complicated by distal embolization that necessitated the use of mechanical thrombectomy for large vessel occlusion. Other studies, they are about the same, between 40 to 70% of good outcome, and mortality about 10 to 15%. So here is a case example: occlusion in the neck again, endovascular advanced catheters, stent implantation, and then balloon angioplasty subsequently, and a nice filling of the carotid and intracranial vasculature as well, and a nice resulting CT. Tandem lesions, that's as I already said, the outcome is not as nice. Reperfusion is slower, reperfusion rates are lower, so is the MRS rates, and mortality is actually higher. And that goes for emergency stenting as well, although this approach looks to be better than mechanical thrombectomy only. As we see here in another case, occlusion of the ICA, MCA occlusion intracranial, which is better appreciated on the angiogram after emergency stenting procedure, and after emergency stenting procedure, mechanical thrombectomy of the intracranial occlusion was performed, and we see a nice filling of the intracranial vasculature as well as the internal carotid. So we see here, had this not been treated in the bifurcation, obviously the carotid here is supplying such a large intracranial territory, the resulting deficit would have been very, very profound. And as we see on the CT, there's no clear area of ischemic stroke. So summing up endovascular treatment, results are better than RTPA alone. Endovascular treatment has very high recoronalization rates, which are predictive of good outcome. However, the best endovascular approach is still to be determined. Moving on to surgery, that's rather old in comparison to endovascular treatment. It's established and rapid. In fact, it's the third most frequent surgical procedure, and about 100,000 cases a year are treated in the United States only. From the surgical and technical point of view, there is no difference between stenosis and occlusion. It's actually easier because you do not need any monitoring when you close the carotid, since it has already been closed. So we place every emphasis on rapidity. The surgery rarely takes more than 1 hour, and the main goal is to restore blood flow as soon as possible. We do not worry about RTPA if it was administered shortly before the surgery. It has a short half-life of about 5 minutes. So by the time you get to surgery, most of it is already has been metabolized. There is limited evidence in the literature in ICA occlusion, in contrary to large studies performed for ICA stenosis. So most of the data come from small case series, and there are no large randomized trials. As I said before, patient selection is essential. In historical studies, there was high morbidity mortality because they were performed without the benefit of CT. And my father wrote in the late 1980s that when the patients present with fixed deficit, they should not be taken to surgery. We shall see that it's not the case, fortunately, today anymore. And comparison of literature nowadays is very difficult because the populations are diverse. Patients are included with very late timing, and patients who presented with stenosis only are also included. So here I show you a case of an 84-year-old woman who presented with complete dense hemiplegia and complete aphasia with an NIH score of 21. She was in the surgical theater very shortly, and in less than 3 hours, we were able to recanalize her carotid. This is the entry CT angiography showing complete occlusion of the ICA, as well as here, large perfusion defect on the perfusion imaging. And so just to show the younger colleagues, this is a standard carotid exposure, common carotid artery, which has been cross-clamped. Clip on the external carotid. Somewhere here is the superior carotid, and I always place only a loop across the internal carotid artery in this setting. Standard arteriotomy is carried out, and we shall shortly see establishment of the black flow. So this is what you always want to see in this surgery when there is occlusion. So we see here a large amount of clots, and this is what was perfect. Let me just show it once more. The rapid backflow from the ICA that is then clipped, and the rest of the plaque and thrombus is removed from the bifurcation. Always it is necessary to flush the ICA as well, as will be done in a moment. So let's see here again, another large piece of clot was still inside, and the arteriotomy is then sutured in a standard fashion. So here is the discharge CT for the patient. No deficit. She left the hospital only with 7th nerve palsy, which was my doing during the surgery due to pressure, local pressure, which resolved within 3 months. The role of surgery, There's also STA-MCA bypass, which is obviously not the first line of treatment in the acute setting and can be considered when everything else fails, and obviously in patients that have a small infarct volume and large salvageable penumbra. We did a review which was published last year on surgery of acute occlusion, and a meta-analysis with my colleagues. We identified more than 6,000 articles, and in the end, we ended up with 10 of them, and that comprised 175 patients. There was a large, very high recanalization rate after surgery, 93%. Neurological improvement immediate was seen in 2/3 of the patients. About the same 2/3 of the patients had actually good outcome on the MRS scale in about 3 months follow-up. And regarding complications, the rates are very low. 5% chance of mortality, 4% chance of early reocclusion, early stroke, and symptomatic intracerebral hematoma. So the results are at least as good as those for our endovascular colleagues. So we should not really let them have all the patients with carotid occlusions. What is the evidence? Apart from RTPA administration, there are no randomized studies performed, and according to the American Heart Association, that's the only class 1 and level of evidence A in ischemic stroke nowadays. And regarding emergency carotid endarterectomy and carotid angioplasty in pure extracranial occlusion only, the role is not well established for either method. So it all comes down to local possibilities and treatment preferences, and obviously team availability. So the goal is to treat the patients as fast as possible, and regardless of which methods in certain cases. Let's have a look at my own series, which was published in Acta Neurochirurgica 5 or 6 years ago. We treated 22 patients with a high admission NIH score with varying neurological deficit, and in 16 of them we noted deficit progression clearly. CT and CT angiography was available in all cases. CTP was not available in 4 patients. Neither of them showed acute ischemic lesions. 9 patients had additional intracranial occlusion or stenosis. We tend to treat the patients as soon as possible as they arrive. These numbers are patients who were either transferred from another hospital or who were highly unstable hemodynamically and had to be stabilized first. In 5 cases, the neurologist managed to administer RTPA prior to surgery. That does not happen anymore. We do not let them do it because there is we have never seen a benefit in it, but it can be done and should be actually done. We were able to restore flow in 16 patients, and we had 2 complications. One was a wound hematoma, which responded to conservative therapy, and we had 1 earlier occlusion of the ICA. Another patient received an ECIC bypass. We were not unable to restore flow in this case. On postoperative day 1, 17 patients improved by 1 or more NIHS point on the scale, and nearly 2/3 of the patients improved by 3 or more patients. 2 patients died, and 14 patients actually achieved a favorable outcome on 1 month follow-up. So I shall cover the last segment of the talk, that is a proposed treatment algorithm. If we have an ICA occlusion and the patient is eligible for thrombolysis, we actually should give him the benefit of it, since it's recommended by the guidelines. If there is clinical improvement, that is perfect, and that's probably at the current moment the end of the story, and the patients can be considered for early recanalization. If there is no clinical improvement, we need to take an active approach. If the patient isn't eligible for thrombolysis, we go by penumbra detection, and if penumbra detection on CT perfusion or MR imaging shows salvageable penumbra and salvageable tissue, again, the approach should be active. If CT perfusion is not performed or is not diagnostic, another nice guidance is by deficit. If the deficit is fluctuating, that is by itself suggestion of a P-number presence. So we again treat the patients actively. If the deficit is fixed, we have a look at the duration of it. Arbitrarily, we set this for 4.5 hours as it has been done by the American Association guidelines. So deficit of short duration, the approach should be active. And when the deficit is long, we treat these patients conservatively and they become candidates for decompressive hemicraniectomy later. Once we have decided for an active approach in the patient, we look at the intracranial vasculature, and if there's a tandem occlusion, the patient is referred to our endovascular colleagues, and if it's purely occlusion in the neck, then that's a surgical case. There are two shortcuts in this rather complex diagram, and that is fluctuating deficit. If there is a patient who comes and is better, worse, better, then that's a clear indication for treatment in my eyes. So we skip all this diagram and treat the patients as soon as possible. The other case is a patient who comes with complete hemiplegia and complete aphasia, and there is normal non-contrast CT. That is, there is no hematoma and there is no complete stroke visible on the contrast CT. I am aware that this is actually controversial, but if this patient is not treated and the disease is left to run its course, then he is left with a very debilitating and very life-altering deficit that is so severe in severity, then that I believe that these patients should be given the chance, given that there is normal CT without apparent ischemic stroke. So in conclusion, ICA occlusion needs a multidisciplinary approach by a neurologist, interventional radiologist, and vascular neurosurgeon. Crucial for the good outcome is fast patient logistic and fast penumbra detection in some cases. Surgery and endovascular treatments are complementary, not competitive, and correct patient selection is crucial for favorable results. Thank you for your attention.
Thank you very much, Professor Benes Jr. It's a wonderful lecture, and we can learn much more things from your lecture. And may I have some questions? Mm-hmm. The first one is, I fully understand and agree with the patient selection, the importance of patient selection. And I also think the patient who has large ischemic penumbra with large vessel occlusion became surgical candidate, you see. And also I think the important thing is to distinguish the etiology of the ischemia. For example, large vessel occlusion caused by cardiac embolism and also caused by atherosclerosis of the carotid artery has two different etiology, and also they should have different surgical treatment. And is it possible for you to distinguish these two different etiology only with CT angiography?
Well, actually, usually no, because sometimes you do not see the ICA. The contrast medium stops in the neck usually, and sometimes you get lucky. You see a ICA stump intracranially from the collateral. That's a clear indication for treatment. And you really are unable to say whether this is a plaque progression or whether it is a cardiac embolism. There were some cases which we were unable to recanalize, and they ended up being chronic occlusions actually. That's sometimes it's undistinguishable on the CT, and these were obviously cardiogenic embolism through collaterals intracranial. With this deficit, I have no other explanation for that.
Okay, thank you so much. And one more question, and the surgical treatment for carotid disease needs general anesthesia compared with endovascular treatment with local anesthesia. How do you evaluate the risk factor of general anesthesia in acute phase, because we have not time to examine the general conditions in acute ischemic patient.
Well, we treat this as if it were polytrauma patients. We do not discuss it with them. We tell the anesthesiologist, okay, we need to do surgery. Go ahead, and they sometimes say he is very. If they say that he is very risky, then we defer the surgery. But that happens very rarely. They usually comply to our request for surgery, because we have convinced them that the outcome is grim. So they are understanding in this setting.
Okay, thank you so much. And do you have some cases which firstly treated with surgery, but it failed to recanalize, and next to endovascular treatment? Do you have such combination therapy?
No. If but that need not be that there aren't any. But in my institution, if we were unsuccessful, that was the end of story. And we usually, what we did during the surgery, we did external carotid plastic. We closed the ICA off and did the external carotid recanalization, or to improve the collateral. And as I said, in one patient, we performed BCIC bypass the next day. That's also a treatment method that can be used.
Okay, thank you. And so you checked the recanalization with CT angiography just after the surgery, or was the day after the surgery?
The day after the surgery.
The day after the surgery.
If the patient improves, then that's clear indication that it's okay. And you see it in the OR, as was seen in the video. I showed that the ICA recanalized nicely because you have a very sufficient backflow from the internal.
Okay, thank you so much.
I think we can open this topic questions.
Yeah.
Firstly, I would like to invite Senior Professor Benes to say his comments.
Well, my son cited my old work from 80s. At the time, we didn't have CT, we didn't have any other diagnostic methods but angiography. And we had a series of patients who were distinctive in only one respect. They all were hemiplegic and or aphasic, but the beginning was different. There was one group who started immediately, like a hammer-like ictus, that they immediately were hemiplegic and aphasic. The other part of the patients, they didn't have this sudden onset. They developed hemiplegia and aphasia over some time. I'm talking tens of minutes. I'm not talking day or hours. It was really fast. But this actually depicts what was the topic of the lecture, actually. It's about the penumbra. Those who had sudden onset, hammer-like, they do not have any penumbra, and the infarction was completed and done by the very beginning. And these patients end up badly. The other part, where the development of the symptoms was gradual or even fluctuating, those fared well because they had some viable tissue, and we preserved this tissue by surgery. So this was somewhat a reflection of old Carter's experimental work, where he showed that the result of ictus depends on the time and length of ischemia. And this, in my mind, is still valid. And we still should be looking for the clinical picture at the beginning of ictus, asking the friends, asking relatives, whomever, just to get this information whether the onset was immediate or gradual.
Thank you very much. I would like to ask Professor Junior Benes one question. That the management of stroke is largely based upon the notion that time is brain. So in your algorithm, you have pointed out that immediately TPA, and if there is no recanalization, if the patient does not improve, you go for surgery. So what is the time cutoff that you would recommend till you should wait to look for whether there is any improvement?
Well, it should be minutes. half an hour at the most, probably. That's what it takes from the patient to be transferred from the CT suite to the stroke unit, and for the nurses to stabilize the patient. That's about the time we should be seeing some kind of improvement. If we do not, then I usually tell the neurologist to stop the TPA, and we proceed with surgery immediately.
Thank you so much. And another question is that the case you mentioned that you did a bypass after 1 day. So is it advisable to, because the time already brain has lost, so it is worthwhile to do a bypass after 1 day?
Well, if I recall this patient well, he woke up in the same neurological status as before and gradually improved afterwards. And we were unable to recanalize the ICA in this case. And the second day, he was again fluctuating as well. So we thought that he would be okay without the bypass at first. But the day after, again, he started developing symptoms. So we did the bypass the second day in a rather acute setting.
Right. Thank you so much. As my dear co-host Liu Bun Seng would like to comment, he said.
Yeah. Thank you, Raja. Thank you, Professor, for a nice presentation. I wish to find out two important things. Is how often do you use a bedside ultrasound machine for a Doppler study or whatsoever that you think is useful in your pre-op assessment? My second question is those patients with post RTPA or even those on antiplatelet prior to the surgery, what are your algorithm in terms of the blood transfusion therapy, and what are the parameters that you're looking at, especially those related to INR and also the APTT ratio? Thank you, Professor.
Okay, ultrasound, then something we used to do, or we tried to distinguish between acute and chronic occlusion, and you can actually check for the patency of the ICA after the surgery visit, the same day or the second day. That's about all of the use I see for it, but maybe it's due to the not so adequate use of ultrasound in my institution. That wasn't the experience wasn't very good, very high with that. And the second question was regarding antiplatelet medication. We give aspirin after the surgery, like 6 hours, depending on APTT. If it's high, then we do not. Obviously, the patient, we give heparin during the surgery. So and that is not cancelled out with protamine after the ICA is recanalized. So if the APTT is high, I believe it was more than 30, then we did not administer aspirin the same day rather than the next already. And if it was slower, then we did give aspirin. And it was, I'm not the best person to ask this. This was the work for the neurologist, actually. So I'm not really sure, but this is somewhat what the algorithm was.
Thank you, Professor.
Thank you very much. There is one question from the audience. Dr. Srihari asks, what is your recommendation regarding the timing of revascularization after stroke?
Well, according to the guidelines, it should be 2 days to 2 weeks. So when the patient presented with stroke due to carotid stenosis and was treated with RTPA, and there was a residual stenosis, we usually did him in the same week. So not the next day or the same day, but something like 2 days to 2 weeks. That's probably the best timing, as it says in the guidelines. Earlier, you run the risk of intracerebral hematoma, and later you run the risk of stroke recurrence.
Right. Thank you very much for all the people who joined in for the discussion. I would like to mention that we can proceed for the second lecture. Professor Takayuki Hara can take over.
Okay, thank you, Professor Benes, for wonderful lecture. And let's move to the next speaker. Next speaker is Professor Dai, John Dai from Shanghai, China. And he will talk about endovascular management of chronic occlusion of extracranial carotid artery disease. Please start your lecture, Professor.
Today, I will introduce some experiences about the endovascular recanalization for chronic occlusion of carotid artery. WHO statistical profile showed that stroke has been the leading cause of lost years of life in China. In recent years, medical endovascular and surgical therapy for ischemic stroke have been improved. This picture shows that the history of the development of acute ischemic stroke therapy. From the intravenous RTPA to the intraarterial thrombolysis and now to the endovascular thromboectomy. In 2015, New England published the 5 RCT trial results. Rapid endovascular thromboectomy treatment was effective and safe in patients with acute ischemic stroke caused by approximal intracranial occlusion of the anterior circulation. In 2018, diffuse-free and down-trail expanded treatment time window from 6 to 8 hours to 16 to 24 hours in some special cases. Chronic atherosclerotic ICA occlusion bring about 10% of TIA and 15 to 25% of ischemic stroke. 2 years risk of ipsilateral ischemic stroke on medical service was 10 to 15%. This incidence was more than twice the annual occurrence of fractured intracranial aneurysm. There were some single-center reports about endovascular recanalization for chronic occlusion of carotid artery. And this is our hospital's paper published in 2014. 40 patients with symptomatic chronic acute ICA were assigned to receive endovascular recanalization and conservative management. The results showed that successful recanalization was achieved in 88.9% vascular penetration in 2 cases. There was no procedure or new cerebral ischemic events. Improvement in brain perfusion was observed in 12 patients on SPECT-CT. The conclusion was that endovascular recanalization is feasible and safe for patients with symptomatic chronic carotid artery occlusion. Successful carotid artery stenting can improve neurological function and global cognitive function than non-revascularization. This picture shows the technology process of chronic ICU occlusion management in our hospital. The patient selection for endovascular recanalization include patients suffered from progression or recurrence of ciliary neurological deficit after documenting the occlusion. The most recent cerebral infarction should be at least 2 weeks before the intervention. Patients with pure ipsilateral stroke and stable neurological status had ipsilateral hemisphere ischemia shown by CTT or SPECT-CT. So complete evaluation must be done during perioperative period, include brain, tissue, cerebral vessel, and CDS. The main complication of endovascular recanalization include vascular injury, cerebral embolism, and hyperperfusion syndrome. This is our team state. 17 patients with symptomatic chronic acute ICA were treated in our team from June 2017 to October 2020. The result shows that successful recanalization was achieved in 82.4%. Vascular penetration in one case. This case failed recanalization. There was no procedure or new cerebral ischemic events. Improvement in brain perfusion was observed in all 40 successful recanalization patients on specialty. 3 months stenosis was observed in 3 cases. This shows the details of all the 17 patients. Now I will show 4 typical cases. Case 1, male, 69 years old. He complained of weakness of right dental and SPF4 oneness. This scale 5. The MR shows the left ICA occlusion and the left frontotemporal lobe infarction. The DA scale shows the left ICA occlusion and the collateral perfusion was from the MMA to ophthalmic artery and the P-count, none from the A-count. The infarction turned into chronic stage according to the MI-BWL sequence. About 100 mg of aspirin and 75 mg of clopidogrel per day were given for 1 week before the endovascular procedure. The patient was treated under general anesthesia. This is the recanalization procedure. Another CM lens 8 French guiding catheter was introduced transfemorally into the left common carotid artery proximal to the occlusion. A 125 cm length 4 French diagnostic catheter was placed in the 8 French guiding catheter and was advanced to the ICA. Then a 150 cm length microcatheter with a 200 cm length microwire was placed in the 4 French catheter. This device was just like a fishing pole. It could provide adequate back-up support and was helpful to pass through the occlusion. When the microwire passed through the occlusion segment, the microcatheter followed to the distal part of occlusion where a hand injection of contrast was performed to confirm the position within the true lumen by angiography. Then 300 cm length microwire was used to exchange the microcatheter and the 4 French diagnostic catheter. Then the 4 mm spider pistol protecting device followed to the distal part of occlusion and was opened. .5 millimeter PTA balloon. Pre-expansion was implemented from the distal to the proximal segment of the occlusion. The Apollo stents and one wall stent was placed one by one in the same sequence. Angiography was performed to examine the patency of the vessel. The spider distal protection device was taken back at last. Suffering bolus was administered to maintain the ACT between 200 and 215 seconds during intervention. Heparin was given for 3 days. Daily aspirin 100 mg and critical grade 75 mg were continued for at least 3 months. The CT image of first day after returnalization showed no hemorrhage and no new infection. The spare CT after the returnalization showed a better cerebral perfusion. 3 months after returnalization, ESA showed that the left ICA was well taken. Case 2. Male, 63 years old. He complained left eye amaurosis repeatedly for more than 1 month. MR showed no infection in acute stage. The PSA showed the left ICA occlusion. Collateral perfusion was from ACOM and the PCOM. This patient, the returnalization procedure was just like case 1. Angiography at last showed the patency of the left ICA. CT image of the first day after returnalization also showed no hemorrhage and no new infection. The spare CT after returnalization also showed a better cerebral perfusion. 3 months after returnalization, ESA showed the stenosis at the C4 segment here. Case 3, male, 76 years old. He complained right limbs numbness with dizziness for more than half a year. MR showed no infection in acute stage. ESA showed the left ICA occlusion. You can see a Carotid residual root was at the beginning of the occlusion. And the collateral perfusion was from MMA to axial artery. And from the ACOM to the left anterior cerebral artery. Then from the PCOM. The reticulization procedure was also just like case 1. Here we can see the microcatheter angiography. Here you find distal protecting device. Here, the spider here. And you see the last, at last, the angiography is the left ICA reticulization. And in this patient, there were a lot of blood clots found in the spider protection device. Here. The SPECT CT after the reticulization also show a better cerebral perfusion. 3 months after reticulization, DSA show that the left ICU was real patient. Case 4, female, 63 years old. She complained the left limb membranous MR to the right ICU occlusion and infarction in the right cerebral hemisphere. SPECT CT shows a hyperfusion in the right cerebral hemisphere. DSA shows the right ICA occlusion, unknown fixed residue root at the beginning of the occlusion. Lateral perfusion was from the MMA to the ophthalmic artery. And they come to the right anterior cerebral artery, then from the decon. This patient was failed to get reticulization. So at last, I will share our team's experience about the key points of reticulization, include the first, fishing polar technique, the second, spider distal protection device, the second, or the third, dilation by small balloon from the distal to the proximal segment. The fourth, stent implantation from the distal to the proximal segment. Thanks for your attention.
Okay, thank you for your wonderful lecture, Professor Dai.
If there are any questions to Professor Vladimir Benes Jr., it is more than welcome.
May I have one more question to the Professor Benes? Okay.
Yeah, sure.
Thank you. And how do you manage the post-operative hyperperfusion syndrome? Do you sometimes experience? Because the patient who has a chronic ischemic disease sometimes have a pyruvate dilation. And for this patient, acute recanalization sometimes induce post-operative hyperperfusion syndrome or some intracranial hemorrhage after the procedures. How do you manage this kind of complication post-operatively?
Well, the patients are always in the stroke unit and they have an arterial line. during the surgery, and we try to keep the pressure about 150 systolic at most. If they are obviously they are dependent on higher blood pressure, then we do not go this low. But 150 is about the top of the systolic blood pressure that we allow in these patients.
Do you evaluate the postoperative CBF study, cerebral blood flow?
We do not do that in this acute setting. We do that for the normal ECIC in chronic occlusion, not in acute occlusion.
Not acute occlusion. Okay.
I have a remark to the second lecture.
Yes.
It's probably not for the author, but for all the young people here. There is a subset of patients with carotid occlusion who escape our attention, not in an emergency, more or less in chronic state. At the time when we did angiography, we had the pseudo occlusions. You were able to trace the dye, very tiny string of dye along the internal carotid artery. And those are definitely the best patients for endarterectomy. The carotid could have been reopened easily. Now with CTA and MRA, these patients do escape our attention because they are dismissed as carotid occlusion. And then the next issue I would like to take out is the issue of surgical recanalization of occluded carotid artery, which is again not impossible. Should you have a backflow on angio going as far back as foramen lacerum, you most likely will be able to recanalize the artery. The lumen behind the plaque is either collapsed or full of thrombus in semi-emergency cases. In chronic cases, it must be collapsed. And then you easily, with endarterectomy, reopen the carotid artery, which is much better maneuver than any ECIC bypass or any other means. And I have nothing against endovascular treatment of these conditions, but again, you may fragment the thrombus and push the emboli distally into the cerebral vasculature, which shouldn't and will not happen with surgical procedure.
Thank you very much. So in that case, we'll wind this up. I would like to invite Professor Takeyuki Hara to give his closing comments.
Yes. Thank you so much. Today, we have great two speakers, one from the Czech Republic and one from China. And we can learn a lot of things for the surgical and medical management of extracranial carotid artery occlusion. So I appreciate so much for these two speakers, and also thank you for all the audience who come from all over the world. Thank you so much.
Thank you so much. So I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers for today, Professor Vladimir Benes Jr. and Professor Dai Jiong, as well as the chair, Professor Takeyuki Hara, for coming here and taking out their time to teach us about carotid artery occlusions. A big thank you to Professor Vladimir Benes Sr., who joined us today for this webinar, and also to my co-host, dear Liu Bun Seng. Thank you so much. Until we all join on next Wednesday, it is bye-bye from all of us. Thank you all for joining.